auscultation. Only if they can't find enough midwives to do intermittent auscultation every 15 minutes and every 5 minutes, then they're going to an electronic monitoring.
Okay. So my question is that, is it true that considering the sensitivity and specificity of CTG machine, the cesarean section has raised with the use of CTG? Is it true?
The sensitivity and specificity for CTG is very poor, depending on which center they do it and whether they are training or not. If you look at the practice in Dublin, they introduced CTG without any training or testing. There have been no studies which have been done after education and testing the people whether they are competent enough. So that is the major concern. So I wouldn't really worry about sensitivity and specificity. I'll more worry about education and assessment, unless I can assess. For example, if I allow you to drive the car, I would like you to pass the license first. There's no point testing you whether you're going to crash the car if you can't even pass the license. So that is the main worry at the UK.
Sir, is there any technique by which this CTG graph can be plotted on the computer screen directly without using that thermal paper? Like ECG graph. Is there any technique by which the CTG graph can be directly plotted or displayed over the computer screen, like the ECG graph, without using the thermal paper for monitoring?
Yeah, many units now don't use any paper at all. So the whole thing is on a screen, and on the screen, like a television screen, you can scroll the CTG up and down. So at the beginning, you can go to the beginning and to the end. And all these CTGs are stored on a server, so you can retrieve it after 25 years.
Thank you, sir.
Sir, there's a question. In the management of a high-risk pregnancy, such as, say, PIH with oligoamnios, we have two investigations, NST and Doppler. So how do we judiciously use these two to give us the appropriate information about the status of the baby?
Okay, so this we are talking about antenatal.
NST.
So antenatally, our protocol at St. George's is very straightforward. Whatever the issue, if it is to do with compromise, then we do a growth scan, a Leica volume, and a Doppler. We don't do a CTG, because CTG is a test for acute well-being. So you can have a CTG now, and a few hours later or a few days later, the baby can die. So we do the CTG only at a later stage. When we are not sure about the Doppler, then we introduce the CTG. Now there have been, I'm sure you heard about the various trials called the Truffle study, which they are looked at computerized CTG and the ductus venosus flow in preterm IUGR, and they are found both to be equal, but that's a computerized system. If you're going to do, then that is quite reasonably good. But again, that can't predict you for 1 week. The baby can suddenly go off within the next few days. So antenatally, I would encourage more to do like a volume, growth, and the Dopplers. No, the CTG or intermittent auscultation is the same for the midwife and the doctor. So in our setup, actually, it is used equally, but just because the resident is there, it doesn't mean the CTG is a must. I think it depends on the case. If it is a high-risk labor, then whether it's a midwife or a doctor, then we would encourage a CTG. But if it's a low-risk labor, then to do the intelligent auscultation first, and then to get intermittent auscultation.
Because at our place, monitoring by CTG is difficult. So many patients in labor with how many number of CTGs coming up?
Yeah, if you are limited number of CTG machines, the best is actually suggested is to do admission CTG followed every 2 hours by 20-minute CTG. So in Singapore, when we practice the 24,000 deliveries, that's what we do, and there is enough scientific papers to show that if you do an admission CTG which is reactive, no decelerations, then you can do it every 2 hours. And depending on the finding every 2 hours, then you can decide whether to do continuous or not.
Sir, high-risk pregnancy, the electronic fetal monitoring, the Canadian recommendations are a bit too elaborate. So what is your suggestion that whether they should be incorporated? Because in India, we are generally doing the intrapartum monitoring by doing cervicograms and by doing the partograph. So do you recommend that all that detailed that the Canadian people have said about the color of liquor, meconium, all those things should be included?
I didn't follow the whole question. I think what you're saying is to cervical dilatation.
Sir, since we don't have a whole lot of electronic fetal monitoring going on in India, we are using the partogram method to do the intrapartum fetal monitoring. So the Canadian recommendations are a bit too detailed regarding the color of liquor and the meconium and everything. So do you recommend, since you are in the UK, that the Canadian recommendations should be incorporated totally?
Well, we don't really, British are British, they don't look into Canadian or American, but I can give you the succinct answer from the FIGO. You know, FIGO has produced guidelines, which I was about to show as the next slide. Meconium with reduced likewise worries, so you have to really think if it is reduced likewise and meconium to switch to electronic fetal monitoring. But if it is abundance of likewise and it is thick meconium, then if the trace is available, then we will do, otherwise they will monitor by intermittent auscultation. So mild to moderate meconium, by and large intermittent auscultation is allowed, but if it is thick meconium, ideally an electronic fetal monitor. The reason is one, that is because if the baby aspirates thick meconium with scanty fluid, then it can cause meconium aspiration syndrome. And the aspiration has nothing to do with acidosis. Usually the deceleration lasts for 2 minutes, then it aspirates. So we don't want, if decelerations are coming, then we try to see whether we should deliver the baby or not.
Hello. Thank you, ladies and gentlemen. Now I think we should conclude here, because there are many questions from all of the audience. Sir, on behalf of the organizers, I extend my thanks to you to coming in Vidarbha region. You must have received so many appreciation in the words, but I will give the tribute in 2 lines. I don't know whether you are fond of Hindi songs, but definitely this tribute is from Lakshmi Madam, from the side of Lakshmi Madam. आपकी बातों में कुछ प्रैक्टिकल से राज है, आपसे भी खूबसूरत आपके फंडाज है. Thank you, sir. Thank you very much.
Thank you very much.
Thank you very much. We now break for tea, but we shall be back exactly at 3:30 because there's lots more coming up. Thank you very much.